As we're discussing blood pressure, it's good to stop every so often and remember the three basic parameters that determine a patient's blood pressure. Every person's blood pressure, every patient's blood pressure is determined by an interaction of these three things. How much blood volume they have. When blood volume is decreased because a patient has lost blood in an accident or in surgery, or when a patient is profoundly dehydrated from perhaps vomiting and diarrhea, that will reduce their blood pressure. Then we have vascular resistance, a change in the diameter of blood vessels. When anaphylactic shock has caused their blood vessels to go from this size to that size, it will drop their blood pressure precipitously. If we want to increase their blood pressure, if we give them a medication that makes their blood vessels go from this diameter to that diameter, we can raise their blood pressure. And then cardiac output. The cardiac output is determined by stroke volume and heart rate. And we know that stroke volume is determined by end diastolic volume and ejection fraction, right? So these are things that also can be modulated in order to keep blood pressure right in the sweet spot, right in that homeostatic zone. Now, what are the natural mechanisms that control these three parameters? Those mechanisms are local mechanisms, and we alluded to these when we were talking about opening and closing of capillary beds. There are local mechanisms that will cause blood vessels to open up or close, and we said that those were particularly factors like the carbon dioxide levels and the pH of those local peripheral capillary bed environments. There are neural mechanisms. Those neural mechanisms, we're mostly thinking about the autonomic nervous system, and we're primarily thinking about the way blood pressure is measured by the baroreceptors on the aorta and up here at the carotid artery that are talking to the medulla oblongata, and the medulla oblongata increasing and decreasing parasympathetic and sympathetic mechanisms to modulate. Mostly we're thinking in terms of cardiac output, although those mechanisms also do speak to vascular resistance, the diameter of blood pressures. Let's speak now for a moment about the hormonal control of those mechanisms. So as a quick review, local control, that auto-regulation, the metabolic waste like carbon dioxide production or lactic acid levels will stimulate vasodilation. Also a quick review, as baroreceptors are measuring blood pressure, if it's too high would have a fast signal rate that would cause the medulla oblongata to decrease sympathetic stimulation and increase parasympathetic stimulation, which would end up decreasing cardiac output. If blood pressure is too low, we've got not enough signal rate, that would cause the medulla oblongata to increase sympathetic stimulation and decrease parasympathetic stimulation. But now let's talk about the dominant endocrine pathway for controlling blood pressure. And it's often referred to as the RAAS pathway, the renin, angiotensin, aldosterone system. Sometimes it's just referred to as RAAS, RAS, and they're calling that the renin angiotensin system. We're going to throw in aldosterone in our discussion, even though our discussion of aldosterone really will extend to when we get to the urinary system itself. So let's follow this beautiful pathway. This is taken from your textbook. If there is lowered blood pressure, and that lowered blood pressure could be because of dehydration, which would decrease blood volume. A sodium deficiency, will refer back to that when we get to the urinary system, or if there's hemorrhage. Those things will cause a decrease in blood volume, and that will decrease blood pressure because blood volume is one of the parameters of blood pressure, right? Now, there are cells in the kidney that are specifically measuring your blood pressure. Cells in the kidney that measure oxygen, we remember that from erythropoiesis, and cells in the kidney that are measuring blood pressure. When they do not get enough blood pressure, they will send out this molecule renin. Renin can be referred to as a hormone, but it acts as an enzyme. Um, and that enzyme will cleave this molecule, angiotensinogen. Angiotensinogen, right here, is made by the liver. Angiotensinogen is always there in your plasma, and angiotensinogen seems to do nothing. It's waiting. It's waiting for the moment that blood pressure is too low. And when blood pressure is too low, the kidneys sense it, send out renin, and they will cleave angiotensinogen, which will turn into angiotensin 1. Quite frankly, angiotensin 1 pretty much does nothing as well. All right, it's just a midpoint. Now, angiotensin 1 is now in your plasma. When angiotensin 1 goes to the lungs, it will be cleaved by another hormone called ACE. ACE stands for angiotensin converting enzyme. And that's a good name for it because ACE, angiotensin converting enzyme, will convert angiotensin 1 into angiotensin 2. Angiotensin 2 is much more active. Now we have got an active molecule that is properly described as a hormone, and angiotensin 2 will cause vasoconstriction, right? And vasoconstriction will cause the arterioles to get smaller, and that by itself will increase blood pressure. But that's not all. Angiotensin 2 will also go to the adrenal cortex and ask the adrenal cortex to release this hormone, aldosterone. Aldosterone is one of the steroid hormones that we learned back in the endocrine system. And aldosterone, its primary target cells are found in the kidneys. When those cells in the kidneys get the message from aldosterone, they will increase how much sodium is being saved by the body. And when more sodium stays in the body, then water follows it, and that will increase blood volume. So through this pathway, angiotensin will directly cause vasoconstriction and indirectly cause an increase in blood volume. And that increase in blood volume will also increase blood pressure. This pathway, I know it is multi-steps, and I know that you're probably tired of thinking about hormones because you thought you could let that go after the endocrine system module. But this is a dominant pathway for the regulation of blood pressure. And believe me, those of you who are going on into clinical programs, you're going to need to know this again. So you may as well learn it now, right? So this is a review. Angiotensinogen, it is a prohormone. It's made by the liver. If you ever have to guess what organ made an individual protein that's found in the bloodstream, if you ever have to guess liver, right? And angiotensin is not doing anything. But if the kidney does not like the blood pressure level, the kidney will release renin. And renin will cut angiotensinogen, turn it into angiotensin 1. When angiotensin 1, it's circulating in the blood. When that blood gets to the lungs, it'll come in contact with an enzyme that is displayed on the surface of lung cells called ACE, and that'll turn angiotensin 1 into angiotensin 2, which is a very potent vasoconstrictor. Angiotensin 2 will not only cause vasoconstriction, but which raises blood pressure, but it'll also induce the release of aldosterone from the adrenal cortex. As long as we're here in the middle of the COVID-19 crisis, let's look at the link that this system has with our COVID-19. COVID-19 is caused by a virus called SARS-CoV-2. Yeah, It's not on the exam, right? And SARS-CoV-2, it enters your lung cells by binding not to ACE, but to an enzyme called ACE2. ACE2 is a very closely related enzyme to the one that is a part of our blood pressure story. But as a closely related enzyme, its job is actually to inactivate the angiotensin 2. ACE was making angiotensin 2. Angiotensin 2 will keep circulating through your bloodstream, raising your blood pressure until it bumps into ACE2, and then ACE2 will cause your blood pressure to go back down. It's there for a good reason. However, this devious virus, the SARS-CoV-2 virus that's causing COVID-19, when the virus goes into your lungs, it convinces your lung cells to let that virus into the lung cells by binding to this enzyme. So, little link there. There is a little bit, this is a nice summary slide for the control of blood pressure by hormones. We have just told the story about angiotensin. These are additional hormones. Aldosterone was on that RAAS pathway. RAAS stands for R, renin, A, angiotensin. The second A is aldosterone, and aldosterone gets upregulated when angiotensin is around, causes your body to retain sodium, and that'll cause your body to retain water, and that will increase your blood volume and increase your blood pressure. Epinephrine and norepinephrine, they increase your blood pressure in two ways. They will constrict blood vessels, but they also will raise cardiac output. So epinephrine and norepinephrine raise your blood pressure. There is a hormone called antidiuretic hormone that we're going to speak about more specifically when we get to the urinary system. Aldosterone and antidiuretic hormone both raise your blood pressure by increasing the amount of blood volume by decreasing the amount of urine, and it also raises blood pressure. The only hormone that we have that decreases blood pressure is atrial natriuretic peptide. So as a handy tool for your future clinical studies, when it comes to hormonal control of blood pressure, almost all of our hormones that regulate blood pressure cause blood pressure to go up. There's only one that causes blood pressure to go down. So it's easier to memorize, this is the hormone that makes your blood pressure go down, and the rest cause it to go up. Then you just need to memorize how the rest of them make your blood pressure go up. So let's conclude this little mini lecture with this brief discussion of anti-hypertension drugs. And I don't mean for you to need to be able to memorize all of these drugs, certainly not for this exam, but this is a clinical link to what we've just been discussing. We know that hypertension is a silent killer. There are many drugs for hypertension, entire categories of drugs. There are drugs that decrease blood pressure by inhibiting that enzyme ACE that was part of the RAAS pathway. If there is no ACE around, then angiotensin 1 cannot be turned into angiotensin 2, and so your blood pressure will not go up. Diuretics, they will decrease your total blood volume by increasing the amount of urine that your kidneys are making. That's a whole different mechanism for controlling your blood pressure. Beta blockers. We remember from the autonomic nervous system that beta 1 adrenergic receptors, when they are activated by epinephrine, they will cause an increase in cardiac output, so an increase in blood pressure. If we have a drug called a beta blocker that will actually block that beta 1 adrenergic receptor, and when it is blocked, then it cannot be activated, and cardiac output will stay lower, and that will also bring down blood pressure. They also cause vasodilation. Angiotensin II receptor blockers are known as ARBs. These are particularly good for hypertension and diabetics. And what do? Remember the RAAS pathway. When ACE turns angiotensin 1 into angiotensin 2, angiotensin 2 will cause vasoconstriction. If we block the receptor for angiotensin 2, then we can prevent the elevation in blood pressure. Calcium channel blockers act directly on the heart to decrease cardiac output. Now, as I said, I'm not meaning for you to memorize all of these medications, but in a clinical program, you will be memorizing all of them. I do want to emphasize two things. Thing one, that all of these drugs and the way they work are the reasons that you need to know how blood pressure is normally regulated in human physiology, right? Because you need to start with the normal to know how all of the abnormal gets treated. And the second thing is this: your patients someday that have high blood pressure, the doctor is going to send them home with medications, and there is a significant chance that the medications are going to cause some side effects like a tired feeling in your high blood pressure patients. So when the doctor is sending that patient home with high blood pressure medications, it is important for you to communicate a couple of things to your patients. Thing one is, yes, I know you feel fine, and so you don't think this is a problem that needs medication, but it will kill you if we don't take care of it. Thing two is, take these medications. If they make you feel tired, that is probably temporary. Stick with the medications for a couple of weeks or maybe 3 or 4 weeks, and that effect will go away. But if it doesn't, we have got entire different categories of drugs that we can use to control your blood pressure. So if you really can't tolerate the medication that the doc is sending you home with, remember, we have got so many alternatives. If this one doesn't work for you, we've got other medications to try, right? We will pick up this topic in the next video.